So good morning, good afternoon to everyone joining today for this hybrid webinar on behalf of March Centre and the International Stillbirth Alliance. We're delighted that you've been able to join us in the room and online today to discuss this really important topic. Where is the money for stillbirths? Over the next hour and a quarter or so, we hope to run you through some really thought-provoking findings from recent studies, but also that chance for discussing and hearing from experts, both within the research and donor funding space, but also parent researchers as well, and looking at how important this issue is. So my name is Hannah Blenko, and I'm a clinician and perinatal epidemiologist here at the London School. And I want to start just by handing straight over to my colleague, Professor Joy Lawn, who's going to give some introduction to the background of this. Following this, we'll have 2 talks followed by a panel discussion and some actions and close at the end. So I'm now going to hand over to Professor Joy Lawn. Thank you very much, Joy.
Thank you, Hannah. Good afternoon. Lovely to see people in the room. Lovely to see lots of people joining online. We've got an amazing lineup for you. But I want to start by, first of all, thanking Hannah, who didn't say that she's one of the world's leading experts on stillbirth data, for setting this up, to thanking March and thanking the Stillbirth Alliance, thanking Sam Palmer from UKRI, who's joining us for the panel, thanking other panel members from Gates Foundation and International Stillbirth Alliance who are online. But first of all, clearly, we need to start by saying, why does this even matter? Why invest? Before we look at the money that's being invested by donors, by research organizations, why invest? So we may think that this is obvious. We think if you've got big numbers, people will invest. But these are huge numbers: 1.9 million stillbirths, 2.3 million neonatal deaths, 0.3 million maternal deaths. Together, a massive burden. And all 3 of these are now have SDGs, but are going slower in the last decade than they were before for progress, despite the fact that most are preventable. So the vast majority of maternal deaths, neonatal deaths, and stillbirths are preventable, and equally preventable across all 3. There are cost-effective things that we have that could make a difference. There's massive impact possible in science, true impact, not just high impact papers, but impact in lives saved. Countries care about this. There are 78 countries with targets for neonatal mortality, around 30 with targets for stillbirths, and virtually all countries committed to maternal mortality reduction, but are off track. And these are the most vulnerable, as we see heartbreakingly in the news every day. When things go wrong, women and especially babies die. So it seems from the evidence, big numbers, possible impact, countries care, vulnerability, that we should be spending a lot of money. But we're here today, as Hannah said, to look at 2 new papers that were published in Lancet Global Health last year. We already had a session where we really focused on the neonatal findings out of this. But what was shocking to us was that the stillbirth was almost invisible in both sets of papers. So we were asked by the International Stillbirth Alliance to do this joint webinar to dig into in more detail. Spoiler alert, both the donor and the research funding is small compared to burden for neonatal, and actually horrifically small for stillbirths. But we're here not to admire the problem. We want to understand why. There are funders who are mentioning stillbirths. There are things that are happening. How can we make the case better together? What is it we're failing to communicate? You know, there is a lot of money being spent. How can we make the case to include stillbirths in this money? And that actually, especially for government money that is being spent, is important to show that accountability also for what families care about. So please, if you want to see the details of the newborn one, look at the previous webinar. But meanwhile, we're going to dig straight into a sub-analysis that we've done specially on the stillbirth side. We're going to start first with the donor funding, and I'm going to hand over to the wonderful Dr. Megan Kumar. She's based in Nairobi. She wasn't able to join us live, but she led this paper in Lancet Global Health, and she's going to talk us through the donor finding from her health economics hat, which mentions newborns, but especially focusing on stillbirths.
Good afternoon.
So here is Megan.
I'm here to present to you the work we conducted that was published in a paper entitled Donor Aid, mentioning newborns and stillbirths, covering the 20-year period from 2002 to 2019. I'm presenting on behalf of an author team from several countries around the world, as you can see on the slide in front of you, and this work was funded through the Nest 360 Alliance. So when we started this work, we started out by thinking, why would there be increased investment in newborn health and stillbirth prevention? The first reason is the high global burden, including almost 2 million stillbirths annually. And what we wanted to see was, even as this has become of increasing political priority with a lot of rhetoric and national and global targets, we wanted to see whether the financing was responding to that rhetoric or not. We see that it's an area of potential high impact to account for both the health and well-being of the baby as well as of the family and the extended community, which means that it would have a high return on investment and affect potentially many sustainable development goal targets. So when we started out, we looked at what was already known about donor funding, and particularly for this subsector of health. And recent publications had looked at MNCH at large and seen about $16 billion of financing annually, although that funding appeared to be stagnating, and we expected that the effect of COVID would be to exacerbate that stagnation or indeed begin to show a reduction. The last analyses focusing on newborn health and stillbirth prevention had been done 6 or 7 years ago, and it had important results that showed almost no funding for stillbirth, with only 9 mentions across the 2.1 million disbursements included in that analysis. And so the questions we came up with were, first, has funding increased over this study period? Who are the biggest funders, and how does that funding link to burden? Is it distributed equitably or not? So we did this using the creditor reporting system that's published by the OECD and benefits from reports by donors, including bilateral, multilateral, and foundations. There were 3.8 million records identified, and we searched them for mentions of related key terms and found about 22,000 records benefiting newborns and or stillbirths. This is a huge effort to winnow that down. And the benefits of using this database are that it's the largest database that exists of aid financing, but it does miss some major donors, including China and Brazil, because it is self-reported data. So the onus is on the agency who's doing the donations rather than reported by others. And finally, we used manual searches and coding by a co-author team, which means that we did filter out some mentions that were inappropriate and ended up with only 46 mentions of stillbirth. So what did we find? When we first looked at aid for newborns and stillbirths in the context of RMNCH, we saw that about 10% of aid in this subsector mentions newborns, and far less than 1% even mentions stillbirths. This has been increasing for newborns over the last 10 years, but for stillbirth it seems to be relatively stagnant. Within the newborn focused area, we can see less than 1% focusing on key interventions that are focused on the newborn themselves. For example, kangaroo mother care or breastfeeding. Many of the mentions of newborn are included in an MNCH package, which may or may not have specific high impact interventions for mortality reduction, as shown in the pink on this slide. In this figure, you can see the total value of global aid mentioning stillbirths. The blue shows anything including stillbirths, and the pink shows a stillbirth focused in financing. Between 2002 and 2009, there are no records of aid mentioning or focused on stillbirths. And between 2010 and 2019, just 46 records focus on stillbirths. This is about $45 million of aid across a 10-year period. In effect, this is a missed opportunity for those donating or contributing aid to count the impact of relevant investments in improving maternity care and reducing infections in pregnancy. In addition, this very limited funding for stillbirths is highly vulnerable. Just 9 funders account for all of the funding across that 10-year period, with the Gates Foundation and Sweden's bilateral funding representing approximately 2/3 of all the records. This is also true of newborn financing, where 10 donors contributed more than 80% of the aid that we recorded. Additionally, we see an opportunity for improved equity in aid allocation. Overall, the main message around equity is that there's still relatively low levels of aid per death as compared with maternal health or other areas in the subsector child health. However, within the least developed countries, which we looked at as a subset of the total recipient countries listed on the right on this slide, you can see there's broad alignment between the mortality burden, shown in the left with stillbirths in blue and newborn mortality in orange, and the amount of aid received over the study period in red on the right, and the blue representing newborn or stillbirth focused interventions. However, there's still, if you compare 2 countries with very similar burdens, for example, Ethiopia and the Democratic Republic of Congo, towards the top of the slide, you can see that the amount of funding for those with similar burdens may still be quite varied. So what does this mean, and what next? First, to summarize our overall findings, there is a major investment globally in RMNCH, with about $15.9 billion per aid in 2019 alone. This is an opportunity for donors to increase the efficiency of their investment by targeting it, and also to think about whether increasing that investment would have a requisite impact on mortality. The current investment in this subsector is mismatched to the burden, as newborns and stillbirths, despite representing about 50% of the mortality, are represented only in about 10% of the aid financing that's provided. And stillbirth funding particularly is low compared to the burden, and the funding is highly vulnerable, with just a few donors contributing the majority of the $45 million contributed over the last 10 years. Overall, the funding for high burden countries seems to also be higher, but the amount per death or per stillbirth is still very low. So from here, we'd like to continue asking questions about why this financing is the way it is. How can we address the persistent underfunding for stillbirths? How do we help bring this issue to the fore? And secondly, how do we hold donor agencies accountable to make sure that vulnerable groups receive as much financing as more vocal groups that are able to speak up for themselves? So I thank you for your time and attention, and I'm sure that through the rest of this webinar, you'll learn a lot more about the state of the art in research on stillbirth.
I think that deserves a very big clap. Really great stuff. So not just highlighting the mismatch between the funding and the burden, but also that it's a missed opportunity, and then asking the whys. So we're going to move forward into the next talk and then have a chance to discuss. And this second talk, these were a paired set of papers that came at the same time in Lancet Global Health. It's about the research funding side. So the donor funding, we'd had a couple of analyses before. This was the first research funding analysis. And it was an amazing team who all did this on the side, mainly of junior doctor clinical jobs. So we're going to have a filmed presentation from Eva Lucades, who is a basic science PhD and then a clinical doctor who's doing her neonatal training. And she's on call today, so she can't join with us. But she will talk you through the people in the team, and then really grateful to her because she has worked extra time to pull out the stillbirth data within this analysis. So just so much learning, very data rich. You may want to watch this afterwards. So over to the wonderful Eva.
Hello, my name is Eva. I'm a pediatrician working in London, and I want to start by thanking the organisers for the opportunity to share our data in this webinar. I'm going to be talking about our project that mapped funding for research related to newborns and stillbirths, and that was recently published in the Lancet Global Health. I am obviously speaking on behalf of a fantastic project team of both clinicians and academics, without which this work would have not been possible. We set out to conduct a review of research funding related to newborns and stillbirths, and we did so using a database called Dimensions. It's the world's largest research funding database with over 7 million grants. In simple terms, it can be thought of as a database like PubMed, but holding data instead on research funding, including where it is going to and who it is awarded by. In terms of what was already known, you will have heard from Megan already on development funding, but we could not find anything in the literature mapping funding specific to research for global newborn health and stillbirths. So, in discussion with experts, we decided on search terms and Boolean operators that we used to identify all relevant grants in the Dimensions database. And we set out to conduct this funding analysis with two main objectives in mind. Firstly, we considered the big picture of what's happening globally, looking at new research funding commitments over a recent 2-year period. For feasibility, we looked at major funders identified in the whole database with any newborn or stillbirth terms, which we defined as those who awarded at least 15 grants worth at least $5 million each, or to include smaller scope but highly active funders, at least 75 grants worth at least $1 million each. Our second objective focused on any funding available over a decade that was given directly to or included at least one research organization hosted in a low or middle income country, or LMIC. We wanted to hone in on the funding landscape where 98% of the burden lies. So after identifying grants that were directly relevant through in-depth content analysis, we then categorized them according to research theme, research type, and we also looked at who the main funders were, as well as where funded research was hosted. This slide summarizes our flow figure from the paper. As you can see, we reviewed over 10,000 grant titles and abstracts in detail. In the end, we were left with just over 3,000 included grants for our in-depth analysis for both objectives. In our first objective, we looked at new grants awarded by major funders in 2019 and 2020. Looking at all newborn and stillbirth related research, we found that major funders awarded 550 grants worth $557 million on average per year. Of these, we found only 10 grants related to stillbirth research, and when looking at the total value of these grants, they represented only $14 million of funding. Often research grants relate to more than one research theme. For example, a grant abstract might mention reducing stillbirths, but also neonatal mortality. We accounted for this, assuming an equal distribution between multiple grant themes, When looking only at the thus assumed proportionate amount funding specifically stillbirth-focused research, this was just over 8 million, i.e. 1.5% of the total yearly average. And this is despite there being a similar number of annual stillbirths compared to neonatal deaths. Another significant mismatch was that just 7% of all newborn and stillbirth research funding was awarded to institutes in low and middle income countries, where almost all of the burden lies. And this mismatch also holds true when looking at stillbirth research. Of the top 13 funders we had identified, the vast majority were from the USA or Europe, and 88% of recipient organizations were also based in Europe or Northern America. This table shows some of the top funders overall for all newborn and stillbirth research, with the US NIH very much dominating. Of the 13 major funders, only 7 funded stillbirth research. Looking here at amounts related to any stillbirth research, you can see that top funders were the Bill and Melinda Gates Foundation, as well as Australia's National Health and Medical Research Council. And the same too come out top when looking at specifically stillbirth-focused research. So whilst for most other research themes, NIH funding normally heavily dominates, stillbirth funding appears to depart from that trend, with Australia and a philanthropic funder coming out top. For our second objective, we looked in detail at a decade's worth of research funding active between 2011 and 2020, identifying grants that had at least one LMIC recipient. Over these 10 years, we found that a total of $484 million actively funded newborn or stillbirth research, and this was through close to 2,000 grants, which, as said, each had at least one grant recipient hosted by an LMIC. Of this, only 30 grants worth $21.9 million related to stillbirth research, with only 12 million specifically apportioned to stillbirth-focused research, and this is just 2.5% of the total. These, note, are total sums for 10 years of active research funding, so we can estimate that over this decade, on average per year, just $1.2 million funded stillbirth research for all LMIC recipients. This ribbon figure relates to total active funding for this decade for stillbirth and newborn related research grants with at least one LMIC recipient over this 10-year period. It shows how funding flows according to World Bank economic groups for the host country of both the funders on the left and recipient organizations on the right. We accounted for the distribution of funding where multiple recipient organizations are named, which is often the case with research grants, and we assumed there to be an even distribution of funds when this was the case. Whilst this figure does not show stillbirth-specific funding in isolation, it illustrates some important contextual points. We found that 83% of funding involving LMIC partners over this time period was awarded by high-income country-based organizations, only 14% by upper middle income and about 2% by lower middle income countries. Of all the grants here with at least one LMIC recipient, only 68% of funding, about 330 million, was directly available to LMIC recipients. Nearly a third was actually co-allocated to recipient organizations in high-income countries. So even if there are large amounts of funding naming an LMIC recipient, vast amounts are co-awarded to high-income institutions. We can see in the purple ribbons that upper middle-income economies funded nearly 69 million to others in the same economic group, which is more than they received from high-income countries. Notably, very few grants had research partners in the lowest income countries. This map again relates to total funding for all included stillbirth and newborn health-related research grants over the 10-year period. It shows the destination of all these grants with LMIC partners. First of all, we can see those in the darkest shade of red represent countries with the highest number of active grants, those being particularly China and Brazil. Interestingly, these countries also had the smallest medium award size at $35,000 and $9,000 respectively. The bubbles here highlight the top recipient countries of those grants and the amounts received, noting the UK to be a major recipient of research funding with LMIC partners, but also that BRICS nations are otherwise key leaders. Also displayed here are some of the top funders of all newborn and stillbirth research in this dataset, showing here again total amounts of active funding and grants with at least one LMIC recipient over the decade. We identified 49 founders overall, and as you can see, the Bill and Melinda Gates Foundation is a top funder, followed by the European Union and the UK government's UKRI. But also note China, Brazil and South Africa featured in the top 10. Of 49 research funding organizations within this 10-year dataset, only 8 funded stillbirth research in LMICs. Looking here at any funding related to stillbirth research, we can see that the UKRI, the US NIH and the Gates Foundation are the top 3 funders. And this also holds true when looking at specific stillbirth-focused funding. We did identify some encouraging trends over time. Over the 10-year period, the total active funding per year for newborn and stillbirth research that included at least one LMIC research organization did increase. Overall, it almost tripled from $23 to $68 million. As shown in this bar chart and in the table. Stillbirth-specific research funding is shown as the light green line in this bar chart. It also increased, both in terms of activity and funding amounts, with more grants and increasing funding amounts from an annual $600,000 to $2.8 million of active funding. What proportion of the total annual active funding this represented also increased, from 2.5% to 4%, maybe indicating a recognition of the key unmet need to improve stillbirth prevention. But of course, this remains a very small fraction of the annual total, considering the huge stillbirth burden that needs addressing. In terms of the research pipeline, overall, nearly half of all funding went towards discovery research, with 20% allocated to interventional research and implementation research, where we included complex evaluations and health systems research, received less than 3%. When looking at the funding focused specifically on stillbirth-related research, and I remind you this was only 12 million awarded through 30 active grants, 3/4 of this went towards discovery research, with less than 5% allocated to interventional research and none to implementation research. So, putting this all together, what we found was that there is a lot of money being invested, and it's not just a case of saying in absolute terms that there's not enough money for research related to newborn health and stillbirths. We estimated $500 to $77 million are newly awarded per year by major funders, and over a decade, about $485 million actively funded research with LMIC partners. However, stillbirth research funding is vanishingly rare, with only 1.5 to 2.5% of total amounts dedicated to this. The good news is that money going towards LMIC partnered research is increasing year upon year. This holds true for stillbirth focused research too, although even in 2020 it was only 2.8 million per year. When it comes to the research pipeline, it's clear that there is plenty of funding for discovering and understanding problems, but given there's widely published literature already covering this, with suggestions for interventions and implementation strategies that can operate in low-resource settings, perhaps more should be going towards these latter two sections of the pipeline. For stillbirth-specific funding, this is particularly marked, with only 3% of funding for interventional studies and none for implementation research. Although LMICs are receiving increasing research funding, within the global context, this is still not at all commensurate with burden, and we found significant amounts being co-awarded to partner institutions predominantly in high-income countries. This really serves as an opportunity to drive more LMIC-led work. We did identify a positive trend here, with increasing research funding activity by BRICS countries. Thank you so much for listening, and I hope you will agree with us that there's an urgent need for more targeted and fairer spending to maximize the impact of research going forward.
Thank you very much, Eva. I mean, wow. I mean, those numbers are just coming past. Was that average of 1.2 million per year across the last decade for research for stillbirths in low-income countries, and a large proportion of that going to high-income partners. Food for thought. I admire Eva's way of getting the positive side through as well, and there is positive, and I think that's what this today is about. Now, Joy, I wonder if I can ask you to come and have a seat just here. Both Eva and Megan are unable to join us today, but Joy was a co-author on these papers as well. So, are there any questions?
I feel like I'm under the interrogation now.
If there are any questions in the room, any for the author team? For anything presented or online, please do feel free to raise your hand in the room or enter online.
Or if you've got insights on why, what to do.
Anything surprise anyone? Yes, Deborah.
The percentage of by basic science versus and there was quite a few years ago, there was a similar analysis for all of child health and found essentially the same numbers of 3%, sort of plus minus going to implementation science. And I still use that, and people say, oh, I'm sure it's better by now. That's really old data. So I'm really excited, and I want that data to show that no, it actually hasn't gotten any better. It's still 3%, and in the last 15 plus years. And so I think that's discouraging, but it's nice to be able to say no, actually, though people talk a lot about implementation science, they're still not funding it.
Thank you very much.
Yeah, no, I agree. I mean, my reflection too is, who here has accessed Dimensions? Yeah, good. The UK RI funder has. I mean, and actually Libby Fitchett, who was the person who, for those who know her, it's amazing. And there are a few published analysis of it, but it's got 7 million grants. It scrapes up everything online in all languages. So all it misses really are pharmaceutical companies, because they don't put so much online till they got the money. So it's really extensive. And we did this so that instead of just saying, oh, we think people aren't mentioning stillbirths or implementation research isn't there, there's actual numbers on it. And then the answer is how to change that.
Excellent, thank you. Any other questions in the room or online? If not, I think we should move on to the next part, which I think is actually the very exciting part. So we've had a lot of facts, a lot of figures. Please do go back and re-listen to some of those talks and let some of those numbers sink in. But actually, what do we do about that? So now we want to switch places again. So Joyce is going to come back over here again now. So we have an excellent panel, which Joy is going to moderate for us. I'll leave her to introduce our panelists today. But thank you very much, Joy.
Well, thank you, Hannah. Yeah, so we really want to move forward to the why and what to do. And we're doing that by picking positive outliers. So we have 2 amazing funding representatives that I'll come to in a minute. But before we do that, we wanted deliberately to start with someone who themselves has been affected by a stillbirth, Grace Mwashagadi from Kenya. And remarkably, having had several stillbirths and also early pregnancy losses, she's now a researcher working on this topic. So we wanted to hear from her, particularly about the donor funding. So we're hearing that it's not a lack of money. There is $15.7 billion being spent each year on RMNCH aid. And what you heard, if you remember Megan's, was 0.003% mentions the word stillbirth. So we want Grace just to say, from her perspective, why does she think that is? And what could be done about that? So this is Grace's take, I hope.
Hello, everyone, and thank you so much for having me here. My name is Grace, and I've been involved in maternal and child health research in Kenya. This was precise study that follows up pregnant women all the way to delivery, to record pregnancy outcomes and look out for hypertension in pregnancy, fetal growth restriction, and stillbirth. And I've had the unfortunate tragedy of experiencing multiple stillbirths. I've had 5 losses, 2 of which were in 3rd trimester. 1 was in 2nd trimester, which was a multiple pregnancy, twin pregnancy. And when I see the 1.5 million cases of stillbirths annually, I know those are not just numbers, but the families affected, because I've been part of those statistics when I experienced the loss. And you know, I'm based in Kenya, and despite the high burden of stillbirth in sub-Saharan Africa, stillbirths largely remain underreported, and its impact is also overshadowed by other maternal and child health issues. And you know, which is still okay, but stillbirth in its own entity is really a heavy burden on healthcare system. And there is emotional and psychological burden on affected individuals, their families, and also long-term mental health challenges that accompany these losses. And more often, particularly in our setup, affected families go through silent grief. It's not an everyday conversation. And therefore, allocating stillbirth funding sends out a really powerful message of empathy and also understanding for the affected families that really go through that loss. And there's associated stigma, there's shame that comes along with having stigma, because it's not talked about in everyday conversations. And therefore, increasing funding for stillbirth will largely really break down those barriers that are associated with the stillbirth and raising awareness about it in different platforms such as this webinar, in conferences, you know, and also it will help increase awareness through raising parents' voices to advocate for change, because they are the individuals that have been involved in it. So hearing them out as we speak through the challenges that we endure after going stillbirth is really a wonderful way, you know, of passing out that message to ensure that there's more awareness about it, people know about it from the people that have been affected. And also, I think raising funding towards stillbirth will really boost development and implementation of evidence-based interventions to prevent stillbirth from occurring. And also for those who have already endured stillbirth, these prevention measures will really address underlying causes that are secondary to the cause of stillbirth, and just reducing the likelihood of recurrent stillbirth for those who have already experienced the heartbreaking loss. And to see that there's more funding driven towards stillbirth, it's a hope for healthier pregnancies in the future for those who have experienced it, because there'll be more improved quality of care and generally respect for maternal care, and it will be a collective effort in improving maternal and child health outcomes. Yeah, thank you.
So many things that we can hear from Grace, including her own story, as she put it, those who have endured stillbirth. But also what she's saying, that by investing in stillbirth, you're also improving maternal obstetric care. We're improving child outcomes. You're helping national development. And then why are we not? It's the stigma. People aren't talking about it. Self-stigma, but also from society. So powerful. I think that's exactly the way to start this panel and to see, you know, maybe we're not having the right voices at the table and they don't have power, and that's why we are where we are. But we're going to move from Grace's story to really the privilege of having with us, oops, we've lost a pen, maybe go back to panel. The best performing funder. So for those who looked all the way through both the donor funding and the research funding, the Gates Foundation came at the top. So we're so privileged, and Cicely, maybe you could put your camera on. We're so privileged to have with us virtually, hot from the neonatal unit in Boston, Cicely Fadell. She's both a neonatologist, an amazing researcher in neonatal encephalopathy, and she's a senior newborn program officer at the Gates Foundation. And as we saw, the Gates Foundation comes out very high on both the donor funding and the research funding. And that's over a longer time period as well. So I'd like to start by asking Cicely, if you could maybe reflect, why do you think it is that Gates has a culture of mentioning and including stillbirths? My fault with the camera. Thank you, Hannah, for sorting me out. We can now see you and hopefully we can hear you.
Yes, hi everyone.
Oh,
Yes, I'm so delighted to be here to talk about what's truly a vital topic. So I'm the resident neonatologist at the Gates Foundation. And so I sit within the maternal, newborn, child nutrition and health team. And I think some of the strong culture of focusing on stillbirth has come from a culture of focusing on impact. And so in order to achieve impact, you have to understand and be able to measure burden. And so you've heard the numbers, which just speak for themselves. And so really then you want to understand the root causes so that you can address them. And just there's historically been an underestimation of maternal and newborn disease burden and impact. And, you know, stillbirth in particular, because we were just mentioning the stigma that's been attached to it. And so this impacts the ability to count dollars and their impact that's going towards those diseases. So you have this persistent undercounting that then leads to persistent underfunding. And so the foundation really tried to understand the burden and then also the causes. And that led to this uncovering of what Grace alluded to, which is that investments to reduce stillbirths really have multiple returns. So you can get double returns, triple returns, because you're really affecting the health of not only the fetus, but then also the newborn that results and the mother and the family as a whole, really. And so some of the efforts that the foundation has supported include the purpose study, which sort of pointed to a common pathway for stillbirth that included things like maternal hypertensive diseases, placental malperfusion, both to the fetus and the mother, you know, a placental insufficiency, abruption, fetal asphyxia, and fetal growth restriction. And so those are really, because of that, have been the areas that our portfolio has focused on, and it really is across multiple levels. So even with, you know, labor ANC care, so getting timely ultrasounds, trying to identify and be preventative about problems. And so we have a AI-enabled ultrasound investment that is looking at it both in terms of ANC care and then also in terms of labor management to try and prevent these common causes. And then, you know, my portfolio, as Joy alluded to, is focused on fetal asphyxia and newborn asphyxia. And so how can we prevent that? And so that is an example of a research focused one where we're trying to understand the underlying causes, and then can we provide treatments that improve survival and intact neurocognitively intact survival. And so I think really what we hopefully can do is exhibit the impact that these efforts have and make a convincing case, both in terms of burden, but then also in terms of cost-effective analyses that really addressing stillbirth has such a benefit in these areas where we're trying to move the needle on reducing newborn rates, stillbirth rates, and then also maternal mortality rates.
Thank you, Cicely. That is so impactful, especially your first line saying about counting the impact. That's really powerful. And I think that seems to be the rational response, but it doesn't seem to work with all other funders. And just reflecting that in the magnitude of the amazing investments by the Gates Foundation, while you're investing more than others, it's still relatively small compared to your overall investments, you know, maybe particularly in some of the infectious disease fields, HIV and the immunization side. Do you have insights, like if you were making the case to others in the foundation for more investments, what do you think strong arguments would be on that?
Yeah, I think one approach that we have taken is sort of an appreciation that it shouldn't be a zero-sum game within the foundation, that really what we need to do is reach out and bring other funders with us. And so that as much as the foundation isn't traditionally thought of as a fundraising organization, we really have been trying to consolidate other funders around the importance of this area. And so even with the focus this year with the United Nations on the maternal and newborn mortality SDGs, the Goalkeepers Conference that the Gates Foundation hosts at the same time was focused on those particular SDGs. And so we actually got a very nice public response and had other people who hadn't traditionally donated money in this area reaching out. And so there's a couple of initiatives that are being started now to increase the envelope overall, so that there's other funders that are in that game along with the foundation.
Great. And for those in the room who haven't seen the Goalkeepers stuff, it's very exciting focus each year at the UN General Assembly Summit. And I, you know, I hope, Cicely, you will take the message back to the Gates Foundation. The most scary talk I ever did was for Bill. And at the end of it, he said, "It's never made sense to me why people don't count stillbirths too." And I thought, oh, I can die happy now. But, you know, I think that's a very rational response based on the numbers. But clearly, whatever we think, actual allocation of funding for donors and for research organizations isn't being driven by the numbers at the moment. So I'm going to come back to at the end to say what one thing would you do. But meanwhile, we're going to leap from you to a fellow funder. I don't know, Cicely, if you ever met the wonderful Sam Palmer, but Sam is now going to take the scary hot seat without the spotlight. So those online, I don't know if you can see the scary hot seat and the so Sam Palmer is a long-standing funder at the UKRI, I believe 15 years.
Yes.
And she's a key part in the team that works on maternal, newborn health, stillbirths, global nutrition within the Applied Global Health group, and you know, one of the few UK funders that we have left that is doing global health. So thank you.
That's okay.
And as you saw, particularly on the stillbirth funding analysis, so UKRI came out in the top 3 for newborn and stillbirth, you know, in the top 5 or 6 for stillbirth any and stillbirth focused. Why do you think UKRI is mentioning stillbirths when others aren't?
That's a very interesting question. Thank you very much. I think what we are acutely aware of is that maternal and newborn health is very, very important, not just within the UK, but also within our LMICs. Back in 2018-19, we did a call with the NIHR in regard to maternal and newborn health, because we were acutely aware that this was an underdeveloped area of research, again, particularly within our LMICs. This was then highlighted across all areas of maternal and newborn health. A very, very good response from our researchers. So we decided that actually we need to continue funding these particular areas. Based on the funding that we have available, we've morphed it more into, as Joy has mentioned, the Applied Global Health Research Board. So more about implementation side of things. So we were talking earlier about not enough implementation science being funded. And this is a very key opportunity area that we do highlight within the call, specifically because we want people to see that we will fund maternal and newborn health. My boss, Jill Jones, is a very strong advocate for this area, and made sure that it was highlighted when we did the scoping exercise that stillbirth was an important area that was potentially being neglected, and that we needed to look further into how we can help you fund this. But we only have a certain amount of money. There's a lot of money being mentioned, which is fantastic. But because we're a governmental department, we have a certain budget that we're allowed to have. And unlike the Gates, which is an amazing foundation, we're unable to necessarily hone in on specific areas. We have to be a little bit more broader. So what we do allow is for people to have response mode applications to come in. So we leave it for you as researchers to decide that this is the area that you want to work in. Now, we do get applications on stillbirth. We have funded one very recently. It's finished in 2023, more around how we work with the mothers and fathers that have had a stillbirth rather than the actual discovery side. So again, more about implementation of how to deal with this. So really what we're looking for is researchers like yourselves and your colleagues to actually want to put applications in on these particular areas. And it isn't got to be just implementation science. We also do discovery science as part of our Population Systems Medicine Board. Again, they have an opportunity for maternal and neonatal health. So it's really down to, like you said, is it stigma? I suppose my question to you guys is, why aren't we receiving applications in on it? What is the reason for us, for you as researchers, not wanting to apply?
Wow, she's clever, isn't she? So we're looking at research funding and she's saying, why aren't the researchers demanding it? That is really profound. So I would be good to hear from people on that afterwards. But so how would that work? People need to be applying across your pipeline and mentioning stillbirth.
Yes.
So on your kind of brain science, all your different committees that you have, people should be putting in on this and saying stillbirth ideas.
Yeah.
Okay, back in our court, guys. And then, within your funding, obviously, UKRI has had a reduction in funding, but you still do have a substantial amount. And of course, the proportion for global is lower and the proportion in this is lower. You said, what I heard is that a lot of the reason you have this is one champion. So how, and I remember because when Jill was setting this up in 2018, she was saying she was trying to make the case for maternal, newborn and stillbirths. And she said she was told, first of all, it's not a big problem. Well, we were able to nix that one quickly.
Yep.
Then she was told there's no science. It's not a science problem. So I don't think, have we, what arguments do you hear? Why do people not invest in this issue?
To be fair, recently we haven't had any feedback on why they don't invest. I wonder sometimes whether it's because the current trajectory is on infections, because obviously with COVID being a very big thing recently, climate change as well, also being very big politically. Are these the areas that we think that's what we need to fund in? But to be fair, we're still open for any types of applications to come in, and the more that you put into us, the more likely it is that we will fund these types of areas. agreed, like with what Grace said, you know, is it because in these countries there's a stigma around it? You know, is it very difficult to get that sort of information out of local communities? You know, are the cultures within those communities, do they, you know, is it a black mark against you if you say that this has happened? So it would be interesting really to find out more about why these applications are not coming in, and is it down to community engagement? Do we need to think about how we work with the communities more, we build that relationship with those communities? I don't know, it's something that I could put out there.
Well, thank you, Sam. We're going to come back to you for your one thing,
Okay.
but we're going to pass on to somebody who I hope will be able to answer some of the things that you've just said. I just want to nix one myth that I've heard a couple of times, is that we don't have numbers on stillbirth rates, and this is not correct. So you can look up the estimates. There are more countries now have data. Since we started doing the estimates several years ago, and now WHO asks countries every year, and most countries said, why did you not ask us before? So we do actually have data. We do, of course, need better data, but we do have data on the numbers, but the stigma is a big issue. So we started this panel with Grace, who is a stillbirth affected parent who's also a researcher. We're now coming to one of the most famous affected parents who also is a researcher, Dr. Susanna Leischer, known to most as Zan. So Zan had the traumatic experience of her first child, Wilder, being stillborn. And she has since then done an MSc actually at the London School, done her PhD at Columbia in this topic, and is now an associate professor in Utah. Now, Zan, exactly this question that Sam, you know, has asked, I mean, particularly where you sit in the US, around 15,000 stillbirths a year. We saw that NIH is hardly funding stillbirths and is, you know, really the massive driver. What do you think are the reasons why the funding is low, and what could be done to change this? Over to you.
Thanks so much, Joy. I'm really happy to be here. And I wanted to just say that there's one number from the presenters that really just hit me, that there's 1.2 million per year going to stillbirth research in LMICs, and that's less than $1 a baby. Pretty striking. So I guess my answer to your question is really in 3 parts. And I would start by putting a human face on stillbirth. As you know and have just acknowledged, Joy, my first child, Wilder Daniel, was stillborn on July 13th, 1999 at full term at 38.5 weeks. And he was such a wanted and planned for baby, and my pregnancy was uneventful. When we went into the hospital, convinced and concerned that I hadn't felt him move over the last 18 hours, the worst that we expected was to go for an emergency C-section. And instead, as some of you have heard me share, the technician scanning my tummy, I was confronted by the sound of static where there should have been my son's heartbeat. Now, Wilder, my son, was born at an excellent hospital in the United States, and I had high quality prenatal care. We were desperate for answers, as so many parents are, and we agreed, therefore, to an autopsy and to extensive testing, but no cause was ever found for Wilder's death. 25 years later, today, I often wonder whether the current evidence-based guidelines on early delivery for some cases of hypothyroidism and cholestasis of pregnancy might have saved Wilder, because at the time that he was born, the research on these conditions had not yet produced any firm guidance on management in pregnancy in order to avert the stillbirths that have been associated with them. But what I do know for certain is that Wilder was one of the nearly 30% of stillborn babies around the world and in the United States for whom no cause of death is known. So not only is this devastating for families, but it means that those deaths can't be prevented because we don't know why they happen. And the second part of my answer, Joy, as to what I would say to try to convince a research funder to focus on stillbirth, is to do what we've been saying already in this panel, which is to look at the potential return on investment. And there's really 2 points here. First is to remind the funder that investments to reduce stillbirth have a triple and a quadruple return, including improvements in maternal mortality and newborn mortality, as well as in child development outcomes. And I would add to that the decreased mental health burden for mothers. And the second point that I would make to the research funder is to consider the vastly greater amounts of research dollars that we've heard are going to newborn deaths, and to examine which of those dollars could go towards research that also includes stillbirth. To take one example, I would guess that the majority of studies on infection or preterm death and newborn death exclude stillbirths from the study population. Such studies could instead include stillbirths as a secondary outcome, producing such a greater knowledge return on that investment for minimal additional expense. And finally, the third part of my answer is to emphasize not just the return on investment in stillbirth research, but the need for that research. As we've been hearing, stillbirth constitutes an immense global public health burden, and indeed they comprise nearly 1/3 of all deaths to children under 5. Yet, as I just mentioned, approximately 1/3 of stillbirths have no known cause, which is a proportion much greater than unknown deaths of newborns. In fact, I checked last night and the global burden of disease doesn't even report unknown neonatal deaths as a category. There's a lot that we do know about stillbirths, but there are big categories of potential causes that remain sorely underinvestigated. A critical area is structural and health system factors, including structural racism. Other areas that remain under-researched include epigenetic and placental mechanisms of effect, and also multi-level studies that look at how possible causes at both the structural and the individual levels interact to cause these deaths. Another key area that requires investment is research into risk stratification, which would allow clinicians to translate the existing knowledge about stillbirth risk factors into tools to identify those mothers at the highest risk for specialized care or even early delivery. And I think possibly the lowest hanging fruit is investment for implementation studies, which, as these papers show, receive a paltry 2.9% of all research funding for LMICs. And I've just learned none of which was focused on stillbirth. Such studies could look at the known high impact interventions that still aren't having a big enough effect on stillbirth reduction to identify effective and efficient ways to increase that impact by reducing blockages, for example, related to training, delivery, access, cultural, or other factors. So ultimately, Joy, I'd argue that research funders have an obligation to align their funding streams with the needs of stillborn babies, the 30% of under 5 children who are literally dying for lack of knowledge and deserve more than 2.5% of that pie.
Thank you, Zan. I mean, so powerful. I'm going to have to listen to your answer again. But, I picked several key things from there, including the issues of structural racism. So just wanted to reflect that, at the beginning of last year when we had the new maternal mortality estimates, that one of the things that really echoed out was the race dimension of that in the US and also here in the UK. And that definitely applies also with stillbirth rates, even more so. So I think that is a key part to bring in as well, including on the implementation side. Maybe, Zan, I could ask, and then I'm going to come to each person in the panel. We're now in the last 5 years of the Sustainable Development Goals. That is a goal for stillbirths as well as the others. There is a time clock going ahead. What would you like to see within the next 5 years that really would make a difference for the funding for stillbirth prevention and research? What thing do you think needs to change?
Yeah, thanks, Joy. It's hard to cram it all into one sentence. Bottom line is I want to see a dramatic increase in funding for stillbirth prevention and research that is, 1, integrated with investments in newborn and maternal mortality prevention. 2, focuses on direct investments in the highest burden countries and subnational areas. 3, is based on much more accessible data to track these investments. 4, tackles the twin issues of taboo and stigma directly. And 5, begins to approach the trajectory that is necessary to align with the massive burden. That's what I would like to see.
Wow. Thank you. Those are really substantial and also about equity and justice. Thank you. Sam, could I ask you to come back to the hot seat and share with us the one thing you would like to see changed? Then we will come to Cicely and then we will move into our closing.
Okay. So I think the one thing that I'd like to see change is probably not change as such, it's increase in the number of applications that we receive, specifically on stillbirth. A lot of our applications that we receive tend to be a multiple subset of lots of different reasons. So actually, we'd like to see applications with stillbirth splashed across the title, because it's very rare that we actually get those types of applications come in. And the more we receive, the greater chance we have of being able to fund those applications, hence the greater chance of publishing, implementing both within the UK and overseas. So that's what we would like, is for you guys to put as many applications in as you can.
Okay, well, hear that, guys, and thank you, Sam. That is one that people should be able to act on. So now, Cicely, what would you say that's one thing you think should change?
So I would like to see an appropriate and true accounting for the impact that these investments return, and also integration of them into the work that's already existing. Because as people mentioned, it's not as though stillbirth is something complete and utterly separate from the work that's being done, but somehow it is often excluded or set to the side. And so seeing an integration of that into the efforts that are already existing.
I love that. And actually one that the Gates Foundation funded is the maternal immunization for Group B strep. And what made it cost effective was counting the stillbirths. And actually Simon Proctor was here at the end and has just left. But that, that is, in the US, that vaccine will be cost effective because of the effect on stillbirths and preterm, more than on the live born baby with GBS. So the panel was just amazing. We're now going to pass on to closing with the wonderful Paula Quigley, who will be introduced by Hannah, who will lead us through the last part with Paula.
Thank you very much, Joy. And a round of applause for the panel and for Joy. Thank you. Hey. So moving towards the end now. So we've had lots of, just apologies for technology. It's always a little bit tricky. Okay. There we go. Right. So as Joy says, we're now going to hand over to Paula, just to think at the end. So we've heard a lot of things and lots of food of thought for us to take away. Sorry, Paula. But now we want to say, well, actually, where do we do? What can we do? We've heard some great ideas of things, but I'm going to hand to Paula, who is the chair of the International Stillbirth Alliance, to talk about through some next steps for action and relevant resources that may help those of us that are looking to say, what can we do next? So Paula, over to you, please.
Thank you so much, Hannah, and greetings, everybody. Really lovely to be here. Privileged to have a few minutes to speak to you all. And thank you so much for an absolutely amazing panel, and for Joy and Hannah for putting this together and facilitating this discussion. So I just want to highlight a few resources that really touch on some of the issues that have been highlighted. And particularly, I want to say that, when we look at the first one, the Global Guide, it's really within that context of placing stillbirth in the continuum of maternal and newborn health. It's not about, driving an agenda only on stillbirth. It is part of maternal and newborn health. So if we can just go to the next slide, please. So last year, we put together this guide with, thank you very much to Bill and Melinda Gates Foundation for funding most of the funding for it, but also bringing together many, many partners who contributed to the development of this guide. It's about preventing and addressing stillbirths, and we wanted to help people to start to be able to do something. And of course, it's only a first step. It's a guide, it's a book. So we need people to use it and to test it out and to put it into practice in their daily work, wherever that is, if it's in a health facility, if it's doing research, whatever. So the idea of this was to bring together existing resources so that we brought them together into one place, and it's very much looking at the whole spectrum through antenatal care, prevention, intrapartum care, and postnatal care. One of the big issues that came out of developing this guide is how little there is around bereavement support. And we know that many people are working in this space. There is some research going on in it, but there's very little there for parents when they have the very traumatic experience. So we want to try to start addressing that. So this is geared for people, for governments, for health professionals, for all sorts of healthcare professionals and organizations to use, and managers, but also for parents and parent advocates. So if we just go to the next one, please, that's the link is there, and you'll get this all shared. Something else we did a couple of years ago with support from the Partnership for Maternal and Newborn and Child Health was the development of these 2 advocacy toolkits. And one is focused around parents. It was developed in Kenya. And one is focused around healthcare providers, and that was developed in India. They are both, very easily adaptable to other contexts. So I really urge you again to look on our website. We'll give you the links to these to see how you can use them, how parents can use them. It's all about increasing their voice. It's all about reducing stigma and strengthening that bereavement care particularly, but not just for the sake of that, to reduce trauma and reduce stigma, but also to help parents move into the next pregnancy, to help them find a cause for their stillbirth if possible, what they can do about it, and how they can try to avoid another one. Unfortunately, we know that people who have a stillbirth are at higher risk of having another one. So we want to do everything we can to help them deal with this trauma, but also prepare for the next steps. So, and the last one is that resource that I just want to highlight is again on our website. This is another initiative that we did also under that PMNCH initiative, and it was looking at where are the support organizations around the world. And of course, you've heard all about where the burden is, 98% in LMICs. Needless to say, most of the support is in countries where the burden is the lowest. That is not to say that that's not important. It's great that those organizations are there, but they're very much focused in the US, the UK, the rest of Europe, Australia, etc. And there are so few in those countries where the massive burden lies. So we want to try to raise awareness about this, encourage anyone who is providing support to join our registry. It's completely free. It's very easy to sign up to, and it's also a support so that people can come and look and see, is there anybody providing support in my country, in my city? It's to try to enable access to those support where they do exist. Unfortunately, we've got a long way to go in terms of making sure that there is more support in places where the burden is still so high. So those are just a few resources that I wanted to share with you, and I encourage you to look at them, to test them, to use them, to share them with your networks and promote them, and give us feedback how we can keep improving. We really want to work further on these. So we're working with different global partners to see how we could best do that. So I'm going to finish there because I know we're out of time. Back to you, Hannah. Thank you.
Thank you very much, Paula, for that. So as Paula says, we're now at the end of our time, but I just want to take a moment to say thank you to everybody who's participated today, who's joined on the panel and elsewhere. We've really appreciated hearing, and there's been so much thought and so much, I think, energy here. I think the one thing I take away, we started off by thinking, well, 1.2 million every year, that's nothing. But actually, I see real potential here. There's lots happening. There's lots of, hearing from our parent researchers, hearing things that are happening on the ground, hearing from funders for ways of going forward. So what I would say is, do stay in touch. Don't let this be the end of the conversation. Let's keep talking. So the International Stillbirth Alliance is there. I think we can put the link in the chat as well. If you're not familiar with this, do go ahead and have a look. If you're working around stillbirth, join us. How can we go together? How can we have stronger voices when we're together? We thank the Newborn Toolkit for supporting with the logistics for this webinar as well. I want to highlight we're not separate. This whole work across maternal, newborn and stillbirth. Do look at this toolkit as well. There's so many important resources there and newsletters there as well. But just leaving you just finally now, the thing is, what are we going to do? What are you going to do? There's something for everyone, I think, that we've seen today. I've taken away the applying for more grants. So come and join us on that. But let's not this the end of the conversation. And let's not, in 10 years' time, let's see the funding increases. But let's close these gaps, particularly for women and their babies in low middle income countries. So thank you very much for joining today, everyone.
Thanks so much. Bye.
Thank you. Really
Thank you.
appreciated, Paula and Cicely. Really appreciated, and Zan.
Thank you, everybody.
Yeah.
And everybody who joined.
Pleasure. Thank you. Thank you for organizing. Bye.
I'm really sorry, but I don't think we can work out how to.
No, so I think if there's questions, they can go in the Q&A. Still, we still have a link open up. Okay, yeah. So please do type your question in the Q&A. That's great.
Thank you. Thank you, Lauren. And thank you, Sam.